This study was recently published, and what it showed was, very importantly, if you count, and this is a little controversial, but if we look at both the days in the hospital over 240 days of follow-up or the days not alive. Dr. Cleveland likes to use days dead. I like to use days not alive. It sounds a little more touchy-feely to me. We can see the days in the hospital did not significantly change. Days in the hospital for heart failure did not significantly change. But if you look at days death or days in the hospital, all cause, especially for heart failure, you can see things got improved, that is, the bars got lower with home telemetry monitoring. And indeed, if you look at mortality, just survival, this is distribution function, you can see how things improved out even past 300 days to a significant difference in the patients who were having home telemetry monitoring, significant difference. If you look at structured telephone support, that's not home telemetry, but that's just calling the patients. If you look at all the different studies that have been done, the p-value is not even significant for overall effect, either for relative risk or for overall effect. You can see by the red arrows. If we look at, and these are combined tables from multiple different sources, but you can see if you look at telemonitoring versus on hospitalization, telemonitoring on mortality, we can see on mortality it actually reached statistical significance with a p-value of 0.003. So telemetry monitoring, home-directed telemetry monitoring, even without the implanted devices, helps. Now, can we improve on this? Because this is not an inexpensive therapy. In this study, the average cost per week was almost $300 per week per patient. Medicare, for example, if I see a patient in the heart failure clinic, pays me $39, and it costs me $13 to develop the bill, just the bill to send to the patient. And it costs me $42 for the clinic room. So you can't make it up in volume when you're losing $12 per patient. It's difficult. So, and this will bring up some questions we'll discuss in the end about who's going to pay for this. One thing that I started working on, one device I started working on in 1992, a long time ago, was implantable hemodynamic monitor, where we could place a catheter and a lead in the patient's, there you go, in the patient's heart and measure right ventricular pressures continuously. This device also measures heart rate, it measures arrhythmias, temperature, barometric pressure, measures a whole bunch of wonderful things. And we've now completed one study with this device. It measures right ventricular diastolic pressure, which is an index of filling pressure on the right side of the heart. It measures right ventricular systolic pressure, and it measures estimated pulmonary diastolic pressure. This is an index, EPAD, estimated pulmonary diastolic pressure, is an index of left-sided congestion. They can be they're both interdependent and independent. They do reflect each other, but therapy of left-sided filling versus right-sided filling is quite different, especially in patients with pulmonary arterial hypertension. And we did complete one large randomized study, which we published in JACC in 2008. But in patients who were class 3, as you can see, we were underpowered. The p-value event rate difference in hospitalization was only 0.058. Based on this, unfortunately, it wasn't quite good enough for FDA approval. So other studies are ongoing. If we look at time to hospitalization, the event we're trying to prevent again, we see in those patients where we had the chronic implanted versus the control, a significant difference in time to hospitalization. Now, and just like with home telemetry monitoring, we added this device, therapy, directed therapy, in a blinded fashion to nurse-directed therapy, where patients are being called an average of every 5 days to see how they're doing. They're doing daily weights, they're doing scales, but on top of that, we're able to reduce the time to hospitalization. We can also, in pulmonary hypertension, we found that we can actually calculate cardiac output. I won't go through the specifics of this, but using both pulmonary artery pressure and right ventricular pressure, we can actually calculate cardiac index, which is very important in the therapy of patients with pulmonary hypertension with an excellent R value. You can see the line of identity here, estimated versus measured cardiac output by implanted other devices done by catheterization. Now, do we need a big device? Well, no. We're also testing this device, about smaller than a grain of rice. As you can see, it's the CardioMEMS wireless heart failure sensor. It's placed in the aorta here. We can also measure aortic pressure, and we can measure pressure in the pulmonary artery. This little device is shoved out the end of a catheter, which we pass into the heart. Takes about 4 minutes to install. Pass the catheter out into the pulmonary artery. You have another little wire that shoves it out the end of that balloon catheter, and it pops open and sits there. It doesn't have a battery. It's activated from an external wand, which transmits energy to it. It activates, and it gives me a very high resolution signal in terms of what's going on in the heart. This is an example of me using that information in a patient who I placed the device in August of 2007, and this is through March 10th of 2009. She didn't listen to me at first, and then she got admitted, and I started having her transmit twice a day. This is a doctor's wife who did not like following my instruction regarding salt. So I became very intense with her. Big Brother Bob was watching, and only by getting her to cut down her salt, by me calling her twice a day. Look at her pressures. This is very high. 50/28. Prior to the implantation of this device, in the year prior, she had 17 admissions for heart failure exacerbations. I started this program here in October of 2007. Since that time, she has not been admitted to this day. In fact, I got her pressures in this morning. They were perfect. She listens to Big Brother Bob now. Look at her pressures. They came down to normal, and they've consistently been normal, other than when she went on a cruise once and ate some salty food. In the Champion study, we're studying this device in 500 patients in a randomized trial. There are other devices being experimented, including edible electronic monitors, these little chips, like smaller than a pill. You swallow the pill, the patch goes in the front of your body, and it transmits information to the patch, which transmits it wirelessly through the internet, tracking heart rate, respiratory rate, temperature, and activity levels in people. These are certainly experimental, but things are coming. Ideally, we'll have a complete system such as this, where the patient at home has a video monitor, he has a wireless connection to a scale, blood pressure cuff, EKG. Patient, if needed, the more sick patient has an implanted monitors for arrhythmia, hemodynamics, and even labs such as glucose. The patient, this information is connected by broadband to a personal health care clinical application, which involves nurse, doctor, care manager, the hospital, the pharmacy, all these things interrelated, so we can actually provide the drugs directly to the pharmacy. The patient has a remote control. They click a button. The TV comes up, talks to them, charts their information, directs their medication, and gives them specific information, as you discussed with me yesterday. We're already working on this. Very interesting. The development will improve, of the future devices will involve improved sensor and communications, evidence-based therapies, clinician-led models of service. These pathways need to be developed, and we're working on that. And they also need, very importantly, to be patient-specific. And very importantly, what is going to be the proper business and healthcare economic model? Indeed, as we look at this, I have some physicians that will actually tell me, well, Bob, I don't send a lot of my patients to you because once I do, they don't get hospitalized anymore. And I get paid if they get hospitalized. I hear that very often, believe it or not. So in summary, I'd like to thank everyone for coming. This is, as y'all know, our third meeting of this sort. I'd like to thank Dr. Bromberg, who's a wonderful role model for me and an excellent leader of this meeting. I'd like to thank the original group. This is us when it wasn't snowing quite as bad back in 2008. And very importantly, I'd like to thank Martine Rothblatt, my good friend and my sister, for having me come here and have some coffee with her. Thank you very much.